Greetings, I'm Dr. Max Gomez. I'm the medical correspondent for CBS in New York, and it is my pleasure to once again be hosting and moderating a webinar on some really important and interesting topics. And tonight we're going to be talking about timely topics in pediatric cardiology. And to introduce our distinguished panel, let me introduce Dr. Christopher Pettit, who will tell us who everybody is tonight.
Good evening. Thank you, Max. As you said, I'm Chris Pettit. I am the division chief of the Pediatric Cardiology division at Columbia University. And it's my privilege and honor to introduce to you all the discussants, the panelists tonight. Dr. Leo Lieberman, who is the section head for rhythm disorders and arrhythmias in children. Dr. Rachel Weller, who is a outpatient and general pediatric cardiologist. Dr. Erica Berman-Rosenzweig, who is the director of pediatric and adult pulmonary hypertension and also a pediatric cardiologist, and Dr. Kaval Faruqi, who is one of our pediatric cardiologists specializing in imaging and cross-sectional imaging.
Terrific. Thank you, Chris. And before we get started, a reminder that you can send in on Q&A any questions, and we'll try to get to those as we move along. And this entire webinar is being recorded and will again be on the Columbia Children's Health website, so that you can refer back to it for all the pearls of wisdom we're going to hear from today, right? So why don't we start with, I always like to start to ask our panelists just for a very brief introduction to themselves, where, you know, what their research interests are and their clinical interests. And Chris, as sort of the chief there, you get to go first.
Thanks, Max. Yeah, so my background is I am by training an interventional pediatric cardiologist, which means that I offer children and adults with congenital heart disease therapies which are non-surgical, so through the blood vessels and sort of using devices, balloons, etc., to fix or improve their heart conditions. That said, I also do a lot of research in terms of improving outcomes in children, babies, and adults with complex congenital heart disease, and I've gotten more interested in sort of moving the field so that children today have even better outcomes than children who were treated 5 years ago or 10 years ago.
Terrific. And I think what will make it easier here, I'll go according to what the pictures are at the top of my screen. Erica, will you tell us a little bit about yourself?
Absolutely. Thank you. I'm Dr. Erica Berman-Rosenzweig, and I am also a pediatric cardiologist by training and the director of the Pulmonary Hypertension Center here at Columbia. Also a vice chair for clinical research in the Department of Pediatrics. And we are one of the few specialized pediatric pulmonary hypertension centers here in the country, and the only one here on the East Coast. And we see a lot of kids with complex congenital heart disease and other forms of pulmonary hypertension. So we have very close interactions with the cardiac team, surgeons, and so forth. And our research is really focused on novel therapies for patients with pulmonary hypertension, whether they be medical, interventional, and even surgical, as well as some of the genetic underpinnings of pulmonary hypertension.
Great, thank you. Kaval, tell us about your area.
Hi everyone, I'm Kaval Faruqi. I'm also a pediatric cardiologist. I'm an advanced imager, so that means that in addition to seeing patients outpatient, I also interpret echocardiograms, so that's transthoracic. Also in the operating room, we use echo to assess the surgical result, as well as fetal echocardiogram. So you know, imaging the fetus for pregnant women. My research interest is specifically in advanced 3D imaging, including 3D printing and virtual reality for pre-procedural planning as well as education.
Some of that, and I think I want to hear some more about this 3D printing and cardiology. Rachel, tell us about your area, please.
Hi, so I'm Rachel Weller. I'm predominantly an outpatient cardiologist, so I see patients up at Columbia, do inpatient service time as well with the more acute kids, and then I have an office on West 86th Street, lovely office. And I'm also interested in working with the fellows. So I direct the fellows clinic, which is actually a great part of my week. And during the downtime, our unfortunate downtime during COVID, because we weren't seeing outpatients, I actually became very involved with the post-inflammatory, the children had post-inflammatory syndrome after COVID. And so I became part of the inpatient, outpatient MIS-C team, and now have continued to follow up with those patients. And now we've been part of research that we're doing, ongoing clinical research into both the MIS-C patients and now looking at sort of long haul COVID patients as well. So children who have symptoms post-COVID.
Interesting. We'll come right back to that, I promise. Leo, tell us about your area, please.
My name is Leo Lieberman. I'm a pediatric cardiologist by training also, like all of us, but my specialty is in pediatric electrophysiology, which is the management and care of rhythm problems in children. This is a very interesting area, which is evolving significantly in the last 20 years where I've been practicing and doing this. And we have new technologies and new advances, and my research interest is in the development of new techniques for ablation for treatment of these arrhythmias, and more importantly, for diagnosing these arrhythmias. That is something that can start at the pediatrician's office and even at home.
Interesting. So let me start out, Chris, actually, let me start out with you for a second, because I think a lot of people in general and even pediatricians don't necessarily think of heart problems in children, be it arrhythmias, congenital malformations, and so forth. Can you just give me a quick overview of what kinds of heart issues you may see, especially as a big referral center, you might see in children?
Thanks, Max. Great question. It turns out that if you look at all babies born across the world, heart defects are the most common birth defects that a child can be born with, it turns out. Many of those can be mild and can be something that just requires surveillance, meaning imaging every so often, a check-in with the cardiologist in clinic. And then some things might require either surgery or a non-invasive procedure in the first couple of years of life. And then rarely there are the infants who are born with complex congenital heart disease. And what we mean by that is a baby who's born who needs either surgery or some sort of procedure in the first 30 days of life to improve their function, perhaps even to save their life. So it turns out that when you work at a big referral center such as Columbia, we see quite a number of infants and newborns who have complex congenital heart disease, but we also see sort of the full gamut, as Rachel will get into a little bit later, from sort of mild things that just require sort of observation and sort of just watchful attentiveness over the lifespan to sort of those more complex things that we see, and certainly children all over the world sometimes get sent here for advanced care, such as what Erica's team can provide and what Leo can provide.
Interesting. So Rachel, let's talk about, I think, something that's on many people's minds, particularly parents right now. School is ending. Vaccinations have now been opened up to adolescents and older. And we've got summer camp coming up. Fall sports will be coming up, fall just going back to school. What is it here that the COVID and COVID vaccines how will they impact kids, particularly when it comes to cardiac problems?
I mean, I guess those are two, it certainly is very different questions. I think the question of sort of COVID itself, a lot of the question has to do with return to sports. If you're acutely sick with COVID, that's one thing, but I think that schools are requiring that pediatricians clear kids to go back to sports. So I think about it sort of, and actually this is how the AAP and the ACC break it down into sort of age group and how sick you were. So if you were, they sort of break it into 12 and above and then under 12, with the feeling be that if you're under 12 years old, no matter how hard you're running, it's probably not such intense activity. I think that as a group, when we actually were putting out some of our recommendations, we disagree with that a little bit, because we do know that certainly there are some kids under 12 who are doing quite intense sports like club soccer. Keeping that in mind, anyone who's doing quite intense sports, you might put them in a different category. And so what you're really worried about is making sure that there's no inflammation of the heart after COVID. And so the recommendations are all based on trying to screen that out. And in general, for pediatricians, the most important thing really is sort of asking questions, the signs of inflammation of the heart, such as chest pain, your heart racing, fainting, and shortness of breath sort of out of proportion. So that's sort of the way that it's broken up. And then if you have sort of mild or asymptomatic, generally you can just clear them with an exam and focus questions. If you're more moderate, then the recommendation really is to at least get an EKG to make sure there's no problems, as well as a good exam. And this can all be done by a primary care doctor. And then for the kids who are quite sick, or the ones that I was seeing who have the inflammatory syndrome after COVID, then we're really doing, significant testing, measuring markers of such as troponin, where you're worried about heart markers, as well as doing echoes, EKGs, sometimes MRIs, and further testing as well. And those kids are often restricted for a longer period of time.
Just one quick follow-up there. If I can use the term, garden variety exam to clear an athlete for school sports or camp sports, for example, what would that entail? I presume you're not necessarily going to go to an EKG or an echo or anything like that.
Correct. So for the more mild ones, really, they're not even seeing us. They're seeing general practitioner, and then just doing a good exam, make sure there's no heart murmur, that their blood pressure is fine. And honestly, to me, history is 99% of good medicine. So really getting a good history about talking about the things that I just talked about, making sure there's no symptoms. And even after fairly moderate COVID, don't necessarily have to see a cardiologist. If the EKG looks good and everything else looks good, then it's still up to the sort of pediatrician. So it sort of depends. Certainly anyone with symptoms at all, either right after or if they persist, then they should see a cardiologist.
Got it. Okay. And we're going to come back to talk a little bit about the vaccine and the impact that might have. But before we get to that, Erica, tell me a little bit about pulmonary hypertension. That's something, again, that I think most people associate with adults, maybe even older adults. When and how do you see that in children? How's that picked up, and where do you go with that?
That's a great question. And, it's pulmonary hypertension, and yet we're cardiologists here. And I think, for those out there, it's the circulation, obviously, that sits between the right and left side of the heart. So the whole gamut from right-sided heart disease, left-sided heart disease, and then other systemic disorders can lead to increased pressure in the pulmonary circulation. And as I said before, we're often working very closely with our congenital heart specialists to make sure that that pressure is in a safe range so that patients can go through surgery. But we are seeing this in a multitude of places. I would say one area that is emerging is in a premature infants. We've seen pulmonary hypertension for years with the rescue of premature infants from ventilator trauma. But I would say these days, as we've gotten better at ventilator support, we're seeing sort of a new era of BPD, and with that pulmonary hypertension, which is probably due to underdevelopment of the pulmonary vasculature and the pulmonary vessels. And so these children are often, our team is often called to help manage them, along with the neonatologist and the cardiologist, because we do have some medications that we can offer until that lung vascular bed is growing further. And then, of course, we see it, as I said before, in the setting of a lot of different congenital heart defects. And, what I can say for the pediatricians out there, there are rare forms of this that are pretty, they can be pretty catastrophic, but in children, The key warning signs, though, just again, a tidbit here, is kids are often misdiagnosed as having asthma. But if they're not responding to the usual treatments, bronchodilators, or you don't hear wheezing, but they're progressively short of breath, it might raise a red flag as to thinking about pulmonary hypertension.
So that's how often they would present or be picked up.
Yes, I mean, we've had kids time and time again that have been misdiagnosed as having asthma, sometimes in the order of a year or two, and that can make a huge difference in terms of the treatment. Other times we've seen kids who were diagnosed with seizure disorders after having had fainting spells from their pulmonary hypertension. So again, it's more, if the story doesn't fit and the treatments aren't working with, what you think you're targeting, to keep that in mind. And the simple screening tests, could be an exam, an EKG, and an X-ray, and that is oftentimes get sort of pointed in the right direction.
And so it's not always or necessarily children who are born with some of these major congenital heart defects. It can be a variety that can be present for a variety of other children.
It can, and again, there are other systemic disorders like connective tissue diseases, lupus, scleroderma, HIV. I mean, it can present in a multitude of associated conditions, and chronic lung disease. So we're always on alert in those children.
Interesting. So, Leo, let's talk about another issue that I think people tend to associate with older folks is arrhythmias. Tell me about arrhythmias in children. Which ones get it, and how is that necessarily picked up?
So arrhythmias in children is a very, very rare condition. We do see a lot of it because we are a tertiary center. We get referrals from all over the place, in Manhattan, Westchester, Queens, Brooklyn, New Jersey. But it is a rare condition. And one thing that the general public always say, you mentioned it at the beginning, is like it's a disease of older people. And I have that a lot. We have probably about 300 patients that we follow that have some type of device, either the defibrillator or pacemakers. And these are children since newborn all the way to college, at any age, even at the newborn period. And every time we talk about a pacemaker, very often the parents say, yeah, but a pacemaker is for the grandpa, it's not for my child. And it's something that we do see a lot, rhythm abnormalities. And the interesting thing about this is that most of the time that children complain of symptoms, chest pain, palpitations, even syncope, most of the time these symptoms are not related to an arrhythmia, are unrelated to an arrhythmia, and related to some minor, things or nothing that is like worrisome or concerning. The problem is that it's very hard to pick up the ones that are concerning, and that's the art of medicine. And this is something that a pediatrician should be able to differentiate when a child is complaining of syncope. It is a benign syncope or fainting episode that a lot of teenagers have when they are dehydrated or things like that, or this is a red flag that there is an arrhythmia going on and it's causing these symptoms. And like Erica said, some of these kids present with other abnormalities like seizures or other symptoms that don't say, hey, I have an arrhythmia. It is our job to figure out this arrhythmia. And we have a lot of tools, which I can tell you later, or how to pick up these arrhythmias in children. And the last thing I want to say, when we say arrhythmias, means just an abnormal rhythm of the heart, and that could go either direction. It could be very slow, some forms of bradycardia, of heart block, or it could be very fast, where they have like ventricular tachycardia or supraventricular tachycardia. Some of these kids actually present with a aborted cardiac arrest. You often hear stories of some teenager dropping dead in the basketball court and gets resuscitated with a defibrillator. So these are different ways that these arrhythmias can present. And fortunately, again, for the general population, this is very rare. For us, it's very common. We see a lot of this.
And I want to get back to some of these arrhythmias because there's a question that came in that I think may very well fall into your area, but I presume obviously an EKG would find or detect this pretty easily. Would you go immediately to an EKG, or just a simple listening might give you some indication?
That's a topic of great debate, and I've been doing this for 25 years, and I don't think we found an answer to that question. The real question is screening EKGs. I mean, obviously, if a child has symptoms, an EKG ought to be done, because you want to rule out things that are easy to diagnose. And if there are symptoms, as I said, palpitations or syncope, an EKG will show you an answer very often in terms of what is the underlying condition that is causing this arrhythmia. So we can see long QT, we can see WPW, we can see conduction disease, we can see a lot of things just a plain EKG. One thing that is another debate, which could take the whole hour, we're not going to debate about that today, it's whether children before sport participation should have an EKG also. I have my personal view on that, but that's still being debated in the literature and in all the forums of pediatric cardiology.
We're gonna come back to that, because there's some interesting stuff that's happened recently that impacts that. But Kaval, certainly last but not least, let's talk about 3D printing and modeling. How does that apply here to cardiology, and particularly pediatric cardiology? I know that's a big area of interest for you.
Sure. So, in imaging, when we assess a new patient that we see, kind of the mainstay of imaging for us is what we call transthoracic echo. So that's basically an ultrasound performed on the chest of the child. And, congenital heart disease means that the heart is abnormal in some anatomic way. And so the way that we kind of figure out those spatial arrangements is that we do something called sweeps. And so what that means is that we go through all the different planes of the heart back and forth, and then in our mind we're supposed to recreate, and we're trained to recreate what that three-dimensional anatomy is. So that's kind of the mainstay. And if there's a patient who needs some additional anatomic imaging, meaning advanced imaging, kind of cardiac CT or cardiac MRI kind of fall under that category. And what that allows us to do is it gives us a whole image of the heart in the chest and three-dimensional data set. So the advantage to three-dimensional printing is that from a three-dimensional data set, either from CT or MRI, we take that spatial information and then I create a digital model from that. And then that is then translated into a physical object, which one of my colleagues can hold in their hand. And, it's self-evident, like the spatial arrangements, you don't have to deduce them, they're self-evident. And so that's kind of the wonderful part of 3D printing, is that the spatial arrangements are so apparent. Now, we use this in addition to, echo, it gives us so much information in terms of the blood flow and the physiology and the function, all of that, but these models have been just really useful for pre-procedural planning, for transcatheter approach. That's not surgery, but that's when a catheter is inserted in the groin or some other vessel, sometimes for an intervention, or surgical approach, as well as education. So, some people are better and some people are not as good in putting these three-dimensional kind of images together. And so these models have been great for kind of helping with that.
Yeah, that's exactly right. I mean, I've looked at a lot of images, and trying to put slices together into a real 3D construct can sometimes be very, very challenging. But when would you move to this kind of advanced imaging, 3D reconstruction, never mind 3D printing? At what point, or where is that most useful, do you think?
Mm-hmm. So, for example, recently we looked back at our own experience over the last 2 years or so, and the patients in which these models have been most useful include kind of 3 overall categories. One is patients who have complex intracardiac anatomy. So that means that there's a number of structures within the heart that we need to understand their kind of position within the heart in order to plan an intervention. So that was kind of one category. The other category was patients with anomalous coronary arteries. What that just means is those arteries that supply blood to the muscle of the heart, those arteries that kind of older people have disease in. In kids, they can come off of the aorta in the wrong spot, and that can predispose them or put them at risk for sudden cardiac death. And so we analyze kind of the characteristics of those anomalous coronaries in order to determine patients' risks. And so we've been creating digital models that allow us to do that in a bit more detail. So that's the second category. And the third category is in preparation for a transplant, heart transplant, or ventricular assist device placement. So that just means a heart pump that allows it aids the heart in supplying enough blood flow to the body. So in placement of that in the chest or heart transplant, replacing the heart in the chest, these models have helped with kind of assessing patients with small chests and whether the device will fit in properly. And so those are kind of the three categories. And then there's a number of other patients that we've created models in, but that's kind of the main type of patients we've used.
Interesting. So Chris, Kaval's kind of teed up a couple of points there for you. I know you mentioned that you're an interventional cardiologist, pediatric interventional cardiologist. Again, an area that many people think is for the old folks with coronary artery disease. Tell me about what sorts of things a pediatric interventional cardiologist might do, and then particularly whether this kind of 3D reconstruction, how useful that would be for you, because I know you do things like closing PFOs and other holes in the heart, but tell me what kinds of things you cover.
Thanks, Max. Yeah, I mean, it's true that the devices that we have at our in our toolbox for treating infants, children, and adults with heart disease, range from closure devices. So there's a hole in the heart, we can close that hole. We can actually balloon open valves or sometimes you actually want to create a hole in the heart, believe it or not, or open up a vessel that's too small by putting in a stent that holds it open. And actually over the past 10 to 15 years, there's been even more further advancements in the available therapies. We can actually perform things like placing a brand new heart valve in. That's become more and more common, starting with Philippe Bonhoeffer, who first put the first valve placed in a human without surgery was a 12-year-old child born with tetralogy of Fallot. So that is now, it doesn't make the news anymore. It's pretty commonplace for us to place a valve in a child's heart without the use of open heart surgery. And I think the field's going further and further towards non-surgical, less invasive ways to treat heart disease, which is fantastic because, as we know, the recovery is much faster. The sort of just the duress and stress of the procedure is much less for the child and for the family. So we expect this to continue to progress. As Kaval said, we're able to do more in the cath lab because we have such better, much more sophisticated imaging. And while Kaval was explaining the idea of three-dimensional imaging, sort of an analogy came to my mind, which is, many organs in the body are kind of like a battery. If you were to slice through a regular old D-cell battery, it's kind of the same, whether you slice high or low or medium, it's kind of the same. The liver, the pancreas, the kidney, you sort of look at it any one way, it's kind of more of the same thing, right? You need enough of it to sort of do its job, but there's a lot of it, and there's more of it if you're bigger, and there's less of it if you're smaller. The heart is completely different. The heart's more like a computer. So you were to look at one part of the computer, that's very different from the lower parts. If you open up take the case off of a large tower, it's very different in different areas. And so you can't understand all of it by looking at just one part. And so this three-dimensional imaging that Kaval and her team can do really are important in guiding our therapies and letting us know what we can do and what we can't do. And then I would just add finally that, you know, as an interventional cardiologist, part of what we do is try to be very inventive. And we apply the tools that are in the toolbox of the adult interventionalist. So, you know, adults have coronary blockages, adults have PFOs, adults have other types of disease, which are very different from infants and children. And yet we can sometimes apply the tools that they have at their avail and apply those tools, which end up being very meaningful solutions for children who have very complex or very severe forms of heart disease. So you have to be a little scrappy as an interventional cardiologist.
Interesting, although I suspect that some of your colleagues in nephrology and hepatology might disagree with your evaluation that it's just more of the same. It's just
That's right. Yeah, that's right.
one big homogeneous organ. Leo, some of the things that interventional cardiologists like Chris would do in adults would be to do some ablations for arrhythmias. Is that doable, or is that a way to treat some arrhythmias in children?
Yes. The arrhythmias in children can have a very broad presentation, and in the prognosis is also very different depending on the age of the patient. So a lot of very young kids and infants that present with arrhythmias, sometimes we treat with antiarrhythmic medications, because often these arrhythmias, they burn out. As they grow, the heart grows and shape changes, and these arrhythmias, they go away. Sometimes they don't, and all the patients, they continue having the arrhythmias. And when these arrhythmias, and I'm talking about specifically about tachyarrhythmias or SVT or ventricular tachycardia. So when these patients have these type of arrhythmias, they are curative modality, and that's why I love my field and love what I do, because these are patients that have palpitations for a long time, and they have arrhythmias, they feel it, and they come in and they get an ablation. And when we introduce catheters through the femoral veins, and we go up and we find this accessory pathway or the area that is causing the arrhythmia, and we burn it, and the patient's cured. That's it, no more arrhythmias, no more palpitations. So it's something we do in children very often. We do it even in young children. We try not to do it in very, very small kids, although I've done it in infants also. But those are the more rare cases. The majority of the kids are like, older kids, or teenage kids that are having palpitations and other symptoms, and they want to participate in sports, and they don't want to take antiarrhythmic medications, so they can have this treatment that it could be curative. One thing I'd like to talk to you about, and maybe we'll do it in the next round, is how we make the diagnosis of these arrhythmias, which is very interesting, and it's something that actually the pediatricians might be interested in also, because as I said before, the diagnosis of these arrhythmias could be challenging, but it could be started at the pediatrician's office.
All right, so hang on to that. We'll come back to that in 1 second, because I want to ask Rachel here. We got a question about vaccines and whether those vaccines may trigger some of this myocardial inflammation that we've seen, the MIS-C, or is that separate? Does it protect? How do vaccines play into this, particularly in kids going back to school and doing sports?
Yeah. So, I think everyone recently has heard a lot in the news about the concern that you can trigger inflammation of the heart or myocarditis after getting vaccine doses in younger kids. So I think it's important, and it certainly sounds scary, and it can be scary, but I think the way I think about it is sort of risk reward. So I think you asked it in a good way, or the person asked in a good way, is can the vaccine be protective? And the answer is certainly yes, because the truth is that when we see COVID infection, even in kids, it can be quite severe. The numbers are much smaller than adults, but just recently, actually, they put out data showing that from March to April, there was an increase in the number of adolescents who are being hospitalized with COVID, and that about a third of them are in the ICU, and that about 30% of them don't have any underlying medical conditions. So this is different from the way we used to think about COVID in kids. And so I think that the idea of a vaccine is really important. We do have a much smaller number who developed that post-inflammatory reaction to COVID. So of course the vaccine, we think, will help with that. There was some concern that because it's an inflammatory syndrome, is it possible that the vaccine could trigger this MIS-C? And we don't know that yet because we tended to see it in younger kids, more around median age 8. So and those kids aren't being vaccinated yet. We do see, though, we're starting to see kids some of them who do have that inflammation of the heart after vaccine, particularly after the second dose. It looks like both mRNA vaccines, the Moderna and Pfizer. I think the good news is the numbers are still quite small. They just came out with it June 10th. The CDC came out with numbers. There's about 450 people who are under 30 years of age who some of it's presumed because they haven't been able to look at all the cases yet to confirm, but may have heart inflammation. But what it's really looking like is that it's pretty mild. There's really been only, at least in this report, 3 kids who ended up in the ICU, one of whom was very, very obese, one who had an infection along with right after the vaccine. But most of the kids are doing quite well. They're having, and I know it sounds scary, but brief episodes of the heart being inflamed, and they're generally doing well with medication and actually going home after a few days. So I think the take-home message is the numbers are very small still, and the kids seem to do pretty well. Of course, as we start to vaccinate younger kids, we're going to have to wait to see. But I think on balance, you'd have to say that the vaccine is protective against a lot of, against COVID, which really is much more harmful to more people and can be more severe. And that's how I think about it.
Right, right. Erica, is pulmonary hypertension something that is normally calls for some sort of physical intervention, or is that something that can be managed medically, which I think will lead us over to Covell. But how is it best managed, or how is it more often managed, I guess?
So, well, just to roll back a minute, I mentioned earlier the patients often present with shortness of breath, and even a kid who, they may just not be keeping up with their peers. And so one of the goals of treatment is to lower the pressure so that in the lungs, so that they can, again, resume more normal activities. But, this has been very challenging to treat historically, because where regular sort of run-of-the-mill blood pressure medications will work on the rest of the circulation, finding a targeted pulmonary vasodilator or medication for the lungs circulation has been very, very, very challenging. We've done a lot of work here and across, really in the last 2 decades to now, thankfully, there are 14 FDA-approved medications that can medically treat this. They don't cure the condition, just like if you had high blood pressure, you take your medicine and hopefully it's under control, but if you stop it, it's going to rear its head again. So these are treatments, not a cure. More recently, we've worked with our interventionalists, and I mentioned surgeons as well, to develop some novel approaches. And that includes something we can do, and Chris can talk about this, a septostomy, which is literally creating a communication between the upper chambers of the heart and the cath lab to serve as a pop-off for the right-sided circulation. And even more recently than that, we've developed a modification of a surgical procedure. It's a shunt procedure from the pulmonary artery to the descending aorta using a unidirectional valve, so that can serve as a pop-off for the circulation. And it really mimics a patent ductus arteriosus, which is another common congenital heart defect, that physiology, and using that sort of congenital heart background and understanding of that physiology, we've been able to help, several kids who have what otherwise would be end-stage pulmonary hypertension. So many advances, and we're still, plugging forward to try and find, hopefully, the cure one day. But for now, we can help these kids much better than we could even a decade ago.
So, Covell, it sounds like this is that some of the things that Erica was just talking about would benefit from this 3D reconstruction and even 3D modeling. But let me ask you this, let me play the devil's advocate for a second, because I see and hear and report a lot on technology, that sort of gee whiz technology, and it looks really cool, but does it really help in the end? Have we had any studies that really indicate the benefit of this kind of 3D modeling and 3D printing, that it really improves outcomes?
Thanks, Max. So it's a great question, because it's something that those of us who've been involved with 3D printing have actually struggled with for quite some time, simply because, you know, when we show someone a 3D model, I have one here. So when I show someone this 3D model, the surgeons, they are able to, you know, they can kind of, they get the advantage of learning about those three-dimensional relationships. And the idea that that has to be quantified in order to kind of demonstrate the advantage is challenging, because then you have to quantify the understanding that's gained from those 3D models. So, you know, multiple specialties in addition to cardiology, like, you know, neurosurgery, ENT, ortho, are using 3D modeling. And so there have been a number of studies in multiple specialties that have demonstrated its utility. A lot of it is based on surveys and basically questioning the surgeon or interventionalist about what the advantage was in terms of understanding using these 3D prints. For cardiology, there's been a handful of studies. We published a study demonstrating the advantage in teaching, for example, for medical students, and the more complex congenital heart disease that we were teaching them, the more increase in understanding that they demonstrated. We're also leading a study looking at ventricular assist device placement in patients with congenital heart disease and heart failure, and whether these prints help surgical understanding as well as decreased time in the operating room. And we're also starting to use these in fetal counseling. So moms who come in and have children or fetuses who have some congenital heart defect, perhaps this can help in you know, increasing their understanding and potentially decreasing parental anxiety. So those are kind of the areas that we're investigating, but certainly it's been a challenge kind of quantifying that advantage.
Yeah, I can understand, but I can say from experience, I had a colleague who had a child with major congenital heart defect, was seen at Columbia, and it was just tremendously helpful to her to understand the anatomy and actually see it that way. You know, it's hard to quantify and hard to put a price on that, obviously. I have one good question at the end here that I want to throw out that I think all of you might be able to chime in on. But Chris, there's one question here about patients, adolescents with sickle cell anemia, and doing a cath to determine pH and manage. Can you tell me a little bit about that? That one, that's an area I'm not really that familiar with.
Yeah, I can start, and then I'll probably defer to Erica, who probably knows far more about sort of when to refer for a cath and not. But I think most of the time, whether it's sickle cell anemia or any other sort of more systemic disease like lupus or other diseases that might result in pulmonary hypertension, usually a screening echocardiogram will be the first thing we would do to sort of get a sense of how the heart's doing, given sort of the changes in heart workload that are result from having sickle cell anemia or any other disease. And if the echo is reassuring and the right ventricle, which has to pump to the lungs, if the right ventricle looks non-dilated, it has normal squeeze, the muscle's not thickened, and there's other indices like tricuspid valve regurgitation velocity that look reassuring, probably wouldn't refer for anything else, but continue to watch that child, you know, whether it's annually, every 2 years, every 5 years, depending on how severe the sickle cell is. And I'd like Erica to sort of probably take it further than that.
That's right on point. And I think, there are systemic diseases that we screen every year or so, and sickle cell would be one of them. But our typical thresholds for what we consider an abnormal echocardiogram, so I think in the question it was a TR jet velocity over 3, for a sickle cell patient, because they typically have high output from their anemia, that would be considered abnormal. And there's some literature that shows even with that slight elevation, they have a higher risk for adverse effects from their pulmonary hypertension. So yeah, we might proceed then, again, if there were some other features that were concerning with a catheterization and recommending treatment and or closer surveillance. And just on that note, sometimes exchange transfusions and some of the routine treatments for sickle cell can just make a substantial improvement, and so that we don't necessarily have to start a pulmonary hypertension.
Good. So let me toss out this question that I suspect may fall mostly into Leo's area, but please, all of you, feel free to chime in. I'm sure that you all saw the recent case of the world-class soccer player who collapsed on the field. We don't have a lot of details, but apparently he suffered a cardiac arrest. It was a defibrillator, and they were able to bring him back. Leo, I guess that brings up what you mentioned earlier, as do we, and some school districts actually recommend or require a little more detailed screening for school athletes, whether it's an EKG, usually just an EKG, I guess. But is there anything that might have picked something like this up? What could have been done? We hear periodically of very advanced athletes collapsing, even though they have gotten to high levels in professional sports or in college sports, whatever. What can we do about that?
So I just want to say first, I'm a soccer fan, and actually I was watching that game when that happened. This is Eriksson, who is a national team in Denmark, and he's like the most professional player you can imagine. He's like a professional soccer player playing for a national team. So these type of individuals, they go through rigorous testing to make sure they don't have any underlying heart condition. And yet he had a cardiac arrest. We don't know the reason why he had a cardiac arrest yet. Hopefully that's gonna come out soon. Certain this was a rhythm related problem because he was resuscitated with the defibrillator. He basically was brought back to life. And you can see actually the picture when he's being taken out of the stadium, he's already awake. Mm-hmm. So I'm gonna go back to the defibrillator, but the point is that even with the most rigorous testing and screening, he still had a cardiac arrest. So whether he had some underlying arrhythmia that was missed during the testing, that sometimes some of those can be missed, or whether he had a myocarditis, and when he had the testing done a few months ago, he was fine. And now he developed myocarditis and he had an arrhythmia related to that. We don't really know what was the underlying condition, but regardless of that, and to me, the most important learning point or message out of this case is the speed of the responders and the reason why he's alive with the intact neurological outcome is because he had prompt defibrillator. So I think that this is the most important thing, and really, unfortunately, this varies in state to state. In the United States and in other countries, doesn't even exist. But the importance of the legislations about the presence of the defibrillator in all sports events is critical, because no matter how much screening you do, you're going to have these individuals that have arrhythmias and they suffer cardiac arrest. And we have actually, the question in the chat was, can this happen to children? And the answer is yes. We have a number of children that get transferred to us from other places, where other institutions around the New York area, where the kids were participating in sports. They had a cardiac arrest. Fortunately, they got resuscitated with a defibrillator, and then they come in for further workup, or whether they need an implantable defibrillator to avoid future events, or whatever diagnosis we need to diagnosis testing we need to do to figure out the cause of it. But yes, this can happen in children. But I cannot stress enough the importance of having a defibrillators available in any sporting event, and this is critical because there are cases that could be missed, and the only way to save those individuals is by prompt defibrillator.
I think you just scared a lot of parents away from letting their children participate in sports, it sounds like. Rachel, does the vaccine have any impact here on sports participation? Any cardiac effects after the vaccine, more specific to sports, arrhythmias, anything of that nature?
No, I mean, it's sort of what I discussed before, just in terms of COVID can potentially affect the heart, and then vaccine potentially could, but the numbers are much smaller. But I think to Leo's point, in all cases, we're thinking about sort of inflammation of the heart. And then just in terms of sudden death, I kind of want to jump from your question a little bit to chime in with Leo. I think one of the things that we think about is, should you have universal EKG screening, or even echo? Some people argue to screen everyone for echoes. And I think that the point is that the numbers, thank goodness, of sudden death in children is still quite low. And that to do mass screenings, number one, being difficult, but if you think about the typical kid who goes for an EKG before they want to start their preseason sports, very often EKGs are not totally normal. And so then they end up having to have a cardiac evaluation for an EKG that's a little borderline. Now they've not only had to go to a cardiologist, they missed their beginning of sports, and 99% of the time, more than 99% of the time, everything is normal. So, and they did a very big study in England looking at all athletes, and the couple who had sudden death, some of them had been screened with echoes prior, because things do develop. So I think Leo's point of defibrillator is really such a critical one. And when you think about outpatient sports in the time of COVID, not in the time of COVID, but particularly now where we're not sure there's a developing disease going on.
Right. Exactly. Good. So I want to be mindful of our time here, and we've only got a few minutes left. And what I like to do is to ask each of our panelists at the end for a little pearl of wisdom, a nugget, a take-home nugget that our webinar viewers can remember from something. What's the most important thing you think that they should remember? Erica, I'm afraid you can lead us off.
That's okay. I said this earlier, but sort of it doesn't fit in, specifically to pulmonary hypertension. If you're treating someone with asthma, that they're not wheezing, they're not responding, think of other potentially other cardiopulmonary disorders, and don't ever be afraid to reach out for help and assistance to work here. That's it.
Exactly. I think that's an important message that we always get across, is that our physicians at Columbia are always available for consultation or referral. Leo, since we were talking about some of those things recently, what would you say you want to make sure people remember? Probably defibrillator, but anything else?
Yes, so a common complaint that pediatricians see are patients that complain of, as I said, fainting, chest pain, palpitations, and the question is when to refer to the cardiologist. Well, we want to continue being in business, so send them all to us. And seriously, there are some red flags, and that's important part of it. I think that the pediatrician should be aware of the red flags. So any of these symptoms related to sports, any of these symptoms that are unusual in presentation, unusual in the age of presentation, any patient has these symptoms with family history that is concerning, like family history of sudden death, an uncle, in a relative, or somebody that dies suddenly without an explanation, and the child comes with syncope. Those things are red flags that should alert the pediatrician that those patients should be referred to a cardiologist for further workup.
Great. Cobble, tell me what we should remember.
I guess speaking more to the parents, if your child is behaving a little bit funny and, have either had COVID or been ill recently, I think, just to have a low threshold to bring them in to the pediatrician so that they can be seen by us if needed. I mean, I've, done a couple of MRIs recently on patients who had a very mild case of COVID, but just didn't feel right, either had shortness of breath or just more tired than usual. And we have found kind of mild findings on MRI that, may explain it, may not, but some things that need to be followed up on. And so, those were all initiated because the child had some type of kind of non-specific complaint that typically is normal. But I think it's just worth, in the environment we're in with, all the illness that we're seeing, that, having them evaluated by the pediatrician first and screened is certainly reasonable.
Fair enough. Rachel, you're up.
I guess really to piggyback on everyone is just, well, I would say in a little bit of the reverse, that I think that luckily most of what we see in children is pretty mild and it is rare, and to sort of just balance your thought process when things come out in the news, to understand that anything associated with a child, it is terrifying because it's your child, but then to really look behind and make sure that we understand sometimes that, things that happen in a child, even if it's just one child, it's horrible, but that's often it is rare. And so just to sort of get the big picture, to get educated and to really understand, and maybe try not to panic, and really talk with your physician about it, and to calm yourself, because I think it's important to touch base with someone who has had the bigger perspective than just what you see in the New York Times. Or
Sure, blame the news person. I always get that.
I'm sorry.
one way or another. But no, I think that's an important message: is don't panic, but look into it if it just doesn't sound right. If your child it just doesn't look right. Fair enough?
Sounds fair.
Chris, as the chief, you get the last word. But let me ask you, just to change it up a little bit, because I've been doing this for an awful long time, 40 plus years, and I've seen pediatric cardiology evolve tremendously in that period of time, as I'm sure you have. You're not as old as I am. How do you see it evolving in the future? Where's pediatric cardiology going to go when you retire 25 years from now?
That's an interesting question, Max. And first, I'll start off by just thanking you for moderating this session. It's been a pleasure to be a part of this. So thank you for that. Where we go as a field and as sort of treating children, infants, and adults with congenital heart disease, I think we'll see that we have a much better understanding of why these defects develop, and a much better way to treat these diseases. I fully expect that we will be using patients' own cells, the patient's own tissues, to derive their own heart valves, their own tissues, to replace, when necessary, their own hearts by growing their own heart valves from stem cells, things like that. What's really exciting about being at Columbia for me is to be surrounded by people like Cobble, like the team you see here, like Erica. This is the team that's actually pushing the field forward, so that 20 years from now, Max, we're not doing things at all like we're doing them today because of the discoveries that are made at Columbia in 2021 and beyond. So it's really inspiring. And the second thing is that this is the team that never says, no, we can't do that. This is the team that always finds a solution and tries to be innovative. And the field of congenital heart disease really rests upon the lessons learned by your back's against the wall, you've got to try something, and you try some innovation, and lo and behold, this one works, and that sheds some new light, some new understanding on congenital heart disease, pulmonary hypertension, arrhythmias, et cetera. So I think but by virtue of the fact of our team always saying we can find a solution, a lot of the innovations, a lot of the discoveries happen here.
Absolutely. Well said. I guess that my take-home message is there's always hope here, and don't hesitate to reach out for help. I want to thank our panelists for a really interesting and informative webinar this evening. I think we've learned a lot. I certainly have. And a reminder that the entire webinar will be posted on the Columbia Children's Health website, so you can refer back to any of the specifics that you may be looking into. So thank you again, and we look forward to seeing you next time. Have a great night.
Thank you.
Thank you. Thanks so much.
Good night.
Good night.